honestly tell, yesterday night also he was telling me, Chandramohan, you circulate as many so that they get benefited. We have to encourage. I understand. In fact, Arun Chawla sir was suggesting that if Apul Goel sir gives one example, then it will be little interesting. Apart from this thing, so that the Xavier sir will explain how in neurological perspective this can be understood faster. Already Xavier sir is doing that with smoking related issues and carcinoma bladder also. Anyway, now I request Apul Goel sir to briefly address about the case control and cohort study so that Xavier sir will take over the program subsequently. Over to Apul Goel sir.
Thank you, Dr. Chandramohan, and thank you, Dr. Arun Chawla and ASU for this opportunity. I think last week's two presentations were very, very meaningful, very, very fruitful. It was a very good discussion, very good presentation. I think the presentations were suited for and aimed towards the postgraduates. It's unfortunate that today postgraduates are not here. So he addressed very, very basic things. I think if anyone is to be initiated into writing papers, into research, these were the very, very basic understandings that he told actually that those two presentations. And cohort study is another important study design. Actually, we have to choose a study design based on the objectives of the study, the aims of the study, the questions that we have. Accordingly, we have to design a study design. So cohort study is a very important, again, a very important study design. And we have already discussed a cross-sectional study and case control study. So Dr. Xavier, please let us listen to you today regarding cohort study. And Dr. Arun Chawla requested that I should give some examples. Recently, what papers have been published in IJU, which cover all these study designs. So I have a 5-minute presentation in the end. Over to you, Dr. Xavier.
Please, Dr. Goel, I think it would be appropriate for you to show those designs now.
Okay.
And then particularly the cross-section study and the case control, which you already concluded. And then even the cohort studies, if you could share, it will actually give me also some good insights. And then from there, we can take it. Yeah, please.
Okay. Okay. So I'll start this, and as I said, I'll give you examples of the study design. And I'll welcome, comments. If you have comments in between also, you want to give certain insights based on these papers that I'm going to show, you are most welcome. So the first presentation was on cross-sectional study. So this is one paper that was published in the January issue, this year, January issue. We publish 4 issues in a year. So every 3 months we have an issue. So this is published in the January issue. So this is a cross-sectional, as I had also, said, mostly cross-sectional study because you are collecting data at a single time point. There's no follow-up. So, and these study designs are very good to see associations. So here, for example, can lesion volume and PSA density play a role in detecting clinically significant prostate cancer in pyroid 3 lesions on MP-MRI? So this is the query. So what you have to do is, you have to see based on the MP-MRI grade 3 lesions. MP-MRI 3 lesions, you have to see lesion volume, you have to measure the PSA and do a biopsy and see whether the patient has clinically significant prostate cancer. So everything is measured once. You have MP-MRI, you have on the basis of which you classify a lesion to be pyroid 3, you have measured PSA. So, and then you are correlating it with clinically significant prostate cancer. So this is the abstract. So the objective of this study was to evaluate the association between the volume of pyroid 3 lesions and PSA density. There's some bit of echo. I'm not sure how it is happening.
Dr.
I think,
Chandramohan, can you make me co-host? Dr. Chandramohan, please.
yes, sir. Yes, sir. Rajendra,
Making the co-host, sir.
not only that, did you start anything side by one more program? Then it will give resound. Stop that.
No, sir, here nothing.
Or else, Arun Chawla, sir, if you are anybody opening two at a time, it will come.
I'll
Only use one at a time, please. Okay, thank you.
Okay.
And host, can you make me co-host? Okay,
Made,
done.
sir, made, sir.
Thank you. Done.
Okay. So, Dr. Xavier, any comment on this?
No, you were showing the methodology in the next slide. Maybe at the methodology part, I can.
Okay. So the objective of this study was to evaluate the association between volume of pyrite 3 lesions and PSA density in diagnosing clinically significant prostate cancer and to assess the sensitivity, specificity, negative predictive value and positive predictive value when PSA density is combined with lesion volume. So to my mind, this is a cross-sectional study where the investigator is measuring values at a single time point. So it's a cross-sectional study. So although the study design is a retrospective single-center study. So this is what it is. They have performed biopsy and seen whether PSA density and in the pyrite 3 scenario, whether PSA density and lesion volume correlates with clinically significant prostate cancer. Okay. Another example of a cross-sectional study, again published in the January issue, correlation of gallium-68 PSMA PET-CT oblique MRI imaging with histopathological characteristics in carcinoma prostate patients undergoing radical prostatectomy. Again, here, to my mind, this is a good example of a cross-sectional study where you are seeing correlations. Measurements have been done at a single time point where gallium-68 PSMA PET-CT MRI imaging, and they are correlating the SUV max with the histopathological characteristics in patients who are undergoing radical prostatectomy for carcinoma prostate. So the study design, again, this is the abstract. So the authors aimed to investigate the relationship between PSMA PET findings there's a thing called SUV max in PSMA PET, and the final histopathology results where we comment on Gleason grade lymph node positivity in patients undergoing radical prostatectomy. So this is a single center prospective observational study, 63 consecutive eligible patients. And these patients underwent a gallium PSA PET-CT with fusion MRI for staging, followed by truss-guided prostate biopsy. And then they subsequently underwent radical prostatectomy and with extended lymph node dissection, and then they correlated the SUV max value with the histopathological findings. So again, to my mind, this is a good example for a case control study. Cross-sectional study. Now coming to case control study, again 2 examples. Again, these were published in the January issue. Factors influencing urinary retention following freehand transperineal prostate biopsy. Insights from a tertiary care center. So what they have done, they have performed transperineal prostate biopsy. And then the outcome can be some of the men who undergo this type of biopsy land into urinary retention. So there are two, one group is patients who went into urinary retention. They are the cases. Those who did not go into urinary retention were the controls. Okay, so you have, and then they are comparing the characteristics between these two groups. Who went into retention, what was different in those patients who went into retention from those who did not. So if you see the study design, they evaluated the risk factors for urinary retention after freehand truss-guided transperineal prostate biopsy. They have data of about 100 patients, and these patients underwent a biopsy. And then 14 of these 100 patients had urinary retention and which required urethral catheterization. And then they compared these two populations. patients who had retention from those who did not go into urinary retention. So this is probably an example of a case control study. Okay, now coming to that we'll be discussing today is a cohort study. So here they are looking again a January issue paper, oncological outcomes and complications following radical cystectomy with or without neoadjuvant chemotherapy, a retrospective comparative cohort study from a single center in South India. So what they have done, they have a large patient group who has underwent radical cystectomy. Some of them received neoadjuvant chemotherapy and some did not. And then they are looking at the outcome. So this is a cohort of all the patients who had undergone radical cystectomy. There are two groups here, patients who received neoadjuvant and there's another group which did not. And then they compare the oncological outcomes and the complications. So this is the abstract. Neoadjuvant chemotherapy in the management of muscle-invasive bladder carcinoma has not been adopted universally. The authors studied the oncological outcomes and complications in patients who underwent radical cystectomy with or without neoadjuvant, and then they looked into all the complications, the survivals, and everything. And another example of a cohort study is assessing neoadjuvant chemotherapy's impact on complications following radical cystectomy. So here the cohort is patients who underwent radical cystectomy and then received neoadjuvant as well. These patients received neoadjuvant chemotherapy followed by radical cystectomy, and then they are assessing complications. So again, this is a cohort example of a cohort study. So this is all that I had to show. Over to you, Dr. Xavier, for any comments and
all very good. I think 4 out of 5 was Dr. Ginil Kumar's papers from his institute.
yes.
So I think he is going to take over your journal and tell. So
Yes.
anyway, I mean, all of them look very nice. I just had one comment about the case control design. If you don't mind showing that once more, Dr. Goel, because we did it last time, and I thought I'll. Are you able to share the slide?
I'll just wait. Probably there's some issue.
The cohort studies, both of them are quite all right. And then in the cross-sectional study, although it was mentioned as a prospective study, it's still, I think post-surgical, we were looking at, the status. It's still a, cross-sectional study. It's fine. Just the case control design, I was a little unclear. So I thought before making any comment, I'll quickly look at it and.
I think I have closed it. I'm not sure what's happening. So documents. Okay. Just give me a moment.
Yeah, sure. Yeah, the case control design, probably slide 8 or 10, I think. Case control. Okay. Yeah. Factors influencing urinary retention following a biopsy, right? Prostate biopsy. So, okay, next slide, please. Risk factors for urinary retention patients. So there are 102 cases retrospectively collected and analyzed. All patients underwent MRI, etc. Results, 14 of 102 had urinary retention. So that's 14% roughly. And okay, go to the next slide. Is there another slide on results?
No, I haven't.
Okay,
See, to my mind, this is the, sorry, please.
No, was it mentioned here as a case control design?
No.
Did the authors, I mean, Dr. Ginil is here, he could clarify, is it mentioned? So as I see, there are 102 cases who underwent biopsy, and we're looking for risk factors for urinary retention.
Yes.
Unless I mean, of course, if I see the full paper, I can. But based on what I'm seeing here, Dr. Ginel, do you want to comment on this? If you recall the details of this
No,
paper,
actually, we studied the risk factors for retention in that study, like
yeah. So did you call it
size
a case control design?
no, I think that it was not a case control.
Right.
Just,
This is, yeah,
I'll
to my
take the
mind,
paper. Yeah,
correct. So to my
I'll
mind
just
also, it's
go
not a
through.
case control design. As we discussed last time, we have a case, right? Whatever it may
We
be. It may be
haven't
bladder cancer.
selected a group of patients and compared, I think.
Right. So this, in my mind, based on what I'm seeing, I could be wrong, but I can look at the full paper and clarify. So we have a group of patients, and even in a this to me looks like a cross-sectional study. There as well, we compute the odds ratios, and we can mention what the risk factors are. Right. So what were the risk factors that we found here? So maybe a table or something would have looked good. But anyway, so just to clarify, and we did that just last week. So we have cases. It could be bladder cancer, it could be renal carcinoma, anything for that matter. And we are looking at risk factors. So we find a matching control, plus or minus 5 years for adults of the same sex. And we go backwards and we look at risk factors for both cases and controls. And we can look at multiple risk factors. So that is a classic case control design. So this, as I see, is a cross-sectional study. And here as well, we can say that these are risk factors and compute the odds ratio, 95% confidence interval, etc. However, a case control design is a little more robust. And as I will be telling you in the next few minutes, a cohort study is even better. So this is the only clarification I had, Dr. Apul Goel. But rest of it is great, and thank you for that. And I'm sure you're doing a terrific job as the editor. And it's quite one is a hard work, but it's also a pleasure to be getting all these papers from different people. But the sad thing is you have to reject so many for whatever reason. And some of them are your own friends, could be colleagues from your same institution, but it's a tough job. Anyway, so shall we get going with the cohort study design for today? Okay.
Thank you.
Right. So
Yes.
for I see several new people have also joined in. So we started off a few weeks ago with an orientation to this course, and we said there are 3 parts to this course. First is the research designs. Second is biostatistics and data management and biostatistics. Third one is research management. So we are now in the 3rd lecture of study designs. We did cross-sectional studies, we did case control designs and registries. Today we're going to do a cohort study, and next time when we meet next, we're going to do a randomized control trial. And Dr. Chandramohan and Dr. Arun Chawla, I'm not sure, last year, I mean, most times in my course, I do 2 lectures for an RCT, because one we need to understand the different nuances. We do one whole week's course in RCTs. I think I shared that with you. There's lots to do, and as always, I will do my best to simplify it. So in case we have scheduled just one for an RCT, I would request that we do 2 sessions for an RCT, and we can split it. So with that, let me share my slides on the cohort study, and let's get going. Yeah. Okay, can you see my slides, please? All right. One second. Okay, so what we're going to do is, what is the design of a cohort study? Second, what are the key issues and challenges? Then we will look at how do we assess a cohort study, the importance of follow-up, what is confounding. Last time we did bias, you will recall, and I introduced you to the catalog of biases at the University of Oxford. And those of you who went to see there, who reviewed that website would have been, I'm sure, would have been very fascinated with that. Then we look at how to analyze a cohort study. What is a relative risk? What is a relative risk reduction? One more R is missing here, I'm sorry. Okay, then what is an absolute risk and also an absolute risk reduction? We look at all of them, and we'll do absolute risk reduction a little bit more when we do the randomized control trial and something that clinicians love, which is number needed to treat. We will review that there. Then we will look at the other way of analysis called the survival analysis. I'll just introduce it here, and then we're going to have a whole lecture during the biostatistics module on survival analysis, and is extremely important for urology, wherein so many new cancer treatments are being evaluated, not just medical. We have medical, we have radiation, we have surgical, and a combination of all of this, and different survival parameters. We look at strengths and limitations and a few examples. Okay, so let us design a cohort study for bladder cancer. So first we need to determine or define the population. So this is the population: bladder cancer, men and women at risk for bladder cancer, not children. Okay, although rarely children can get. So from that, we sample and we take a group of people without bladder cancer. We are very sure that they don't have bladder cancer. Of course, you're not going to do a cystoscopy in normal people to check whether they have a bladder cancer or do a biopsy clinically. Okay, clinically you determine, and if at all you do a urine test and examine urine cytology for. Okay, they don't have bladder cancer, and your hypothesis is that smoking causes bladder cancer, or smoking is implicated in bladder cancer, and I want to look at smoking. So you collect smoking history very carefully. So in this group of people, some of them are smokers, some of them are not smokers. That's fine. So we follow them up over time. So this arrow becomes important. So if you take people in their 30s, you have to follow them up for 20 years at least, 20 or long time you have to follow them up. Okay, so we follow them up, and some of the smokers develop bladder cancer. Some of the smokers who smoke the same amount have no bladder cancer. Some of the non-smokers develop bladder cancer. Some of the non-smokers don't develop bladder cancer. So we have 4 groups of people who smoke and don't smoke, who have bladder cancer and don't have bladder cancer at the end of a 10-year follow-up or a 20-year follow-up. Okay. So now you're only doing bladder cancer. You're only looking at smoking. This is a very classic, it's an elegant design. However, it's not so efficient. Remember, imagine, doing a study for so long and assessing people for bladder cancer. Therefore, I would say that why do you stopping with bladder cancer? Why not people look at all types of cancers? So that means rather than just no bladder cancer, you collect people without any cancer. Clinically, they don't have any cancer. Okay, or people without chronic disease, and then you look at multiple exposures. Why only smoking, not smoking? So look at diet, look at maybe even family history, look at alcohol consumption, look at frequent urinary tract infections, whatever. Multiple exposures we can look at, and we can look at multiple cancers, any cancer that people develop or any chronic disease. So let me go back a few. While this is a very elegant design, it's not so efficient. So we'll do a design like this. So this is also possible. So this is a classic cohort design. Once again, what is the definition of a cohort? Cohort, the English meaning of the word cohort is a group of people with something in common. What do these people have in common? These people are middle-aged people without bladder cancer, but with a risk for developing bladder cancer. It could be, right? Or they could be a group of people with a particular exposure. They could have worked in an asbestos factory. They could have worked in some other chemical factory, right? And then you want to follow them up and see what happens to them over a period of time. Okay, so this is the classic cohort design. There are 6 important features of a cohort study. First, it is the best way to ascertain incidence and natural history of any disorder. No other design you can do this. Next, very important, temporal sequence. Temporal means time. What came first? You'll know very clearly in a cohort study, because right? Is it the exposure or is it the outcome? So a putative cause and outcome relationship between a cause and outcome is usually clear or invariably clear. Let's put it that way. Then you can measure multiple outcomes, either a single exposure or multiple exposure. Superb design. And lot of what we know today in medicine and what we do has come from cohort studies. Cohort studies, we understood the disease well, and then we did randomized trials to evaluate treatments. So it's a beautiful design, and I'll show you some good examples from cancer itself, including urology cancer. And once again, as I repeatedly tell all of you, hopefully my sessions, and as Dr. Goel said as we started, I make things as simple and clear as possible. At the end of a working day and a working week, we don't want heavy stuff. Okay, it's actually easy to teach complex stuff. But I'm simplifying it, not only for us to get clarity, but hopefully to inspire all of you, particularly the young people. Okay, I want to do this for India. I want to do this, and with the support of seniors from the society, and 5 years, 10 years down the line, write big grants, get these funding, and do this high quality studies. So also useful in studying rare exposures. The Bhopal gas tragedy that happened in the 80s, I think it happened, right? Many of us were in school or even younger, and they follow them up. And then there's some data from there. The Hiroshima Nagasaki bombing, and the Chernobyl bomb, gas leak, right? All of this created very rare and valuable exposure. Unfortunately for the people who survived, they had some really nasty outcomes, but it was good for us to follow up from a scientific point of view. It reduces the risk of survivor bias, which is a big bias in all other studies. In a cross-section study, we can only study people who are alive. Even in a case control study, the case is alive and willing and able enough to give you data. But in a cohort study, gather a group of people, and those who unfortunately die is an outcome for us. And that is valuable data. And finally, eliminates recall bias. Isn't it wonderful to eliminate something nasty? Right? Recall biases are really bad for us. So we need to eliminate that. So these are 6 important features of a cohort study. And the more and more you look at this and think about this, you'll realize that for research, these are important parameters for us to have in mind, and it gives us very, very valuable data. Disadvantages: time. Takes a long time to design a good study. In fact, it is one of the toughest studies to design, conduct, analyze. It's tougher than an RCT. Okay, right? And cost. Many people don't understand the value of cohort. RCT, we get a new treatment. Let's do that. And guidelines are written, etc. But cohort studies are what lays the foundation for an RCT. So time, cost, and selection bias. Sometimes exposures may hide the confounders. Anyway, let's not worry about that for now. It's not good for rare diseases in population cohorts. That means you need, suppose it's 1 in 100,000, right? You need 500,000 people and you'll get 5 outcomes. So that's a bit of a challenge. On the other hand, a case control design is better because you already had the outcome. Okay, loss to follow up is a big problem. And another thing that happens is changes in exposure status with time, keeps varying. But if you design your study well and you collect the data, you can estimate the dose of exposure, how much of exposure they had, and what are the outcomes because of that. 2 types of cohort studies: prospective cohort studies and retrospective cohort study. Sometimes we get a little confused here, right? What is prospective and what is retrospective? Prospective, you collect a group of people, collect data going forwards. Okay, exposure and outcome from this point onwards, we go forward. Retrospective, on the other hand, is collecting data from databases that are already existing. Now, Dr. Ginil can do that in Amrita because they have good data systems from many years now. And then you can go there and get reasonably good data. But in certain government hospitals and in other institutions where data collection and management is not good, it's difficult to do retrospective studies. People still do that. Lots of data are missing. They do some adjustments and that doesn't work well. Okay. So you go backwards and you collect exposure and outcome from that point forward. So now if you have good data systems in our hospital, we start 1st of January year 2000. Okay, up to now we can go 25 years forward, right? And you collect, so everybody who were admitted, let's say with bladder cancer in year 2000, we follow them up, and let's assume it is 1,000 people, for example. You follow up 1,000 people from there up to this point till we have this data. So it's a 25-year follow-up. Okay, so that is also possible. I'll show you. I have a diagram to show you. Here are the retrospective cohort. So this is where we are, present time. Okay, and we are going backwards, but the investigation direction is forwards. Okay, so we have a cohort of healthy people here. Okay, some of these people are exposed, some of them are not exposed. Those who are exposed or had a particular risk factor exposed, they get a condition or they do not get a condition. Similarly, non-exposed people also, they get a condition or an outcome or without that condition. All right. So let's assume this is a 10-year period, but you are here. You go here and then you start collecting data going forwards and you measure this exposure and you get all of these outcomes. So if you have good data systems, this is possible even in Western countries where data systems are so much better than ours. It's not good enough. It's not good enough. Anyways, how do you select study cohorts? We can have special exposure groups because they've had an unusual exposure, and I gave you 3 examples already. Okay, the Bhopal gas leak or the Chernobyl gas leak or the Hiroshima Nagasaki bombings, all of them looked at radiation exposure and toxic gas exposure and went forward, and we roughly know what kind of outcomes people had. Much higher rates of cancers and birth defects, etc. Right? Certain work experiences, unusual lifestyle or work experience can be a cohort as well. So that is a special exposure group. Then we have the general population sample, and we need to ensure that we have sufficient heterogeneity to the exposure of the suspected causative factor or the etiological factor. Now, how do we assess exposure? So we have to design our forms really well and have uniform systems so that people can collect data on exposure. It needs to be objective. It can be acute exposure at different time points or sustained exposure or chronic exposure. All of that we can collect. Now, we also look at exposure accrual or risk accrual. Something keeps on adding up. It builds one over the other. Okay, so that is something that we collect as well. So we can measure change in exposure status over time. We can also measure levels of exposure. So designing this case report form is quite important and also tricky. Okay, let's take once again, go back to this example of smoking. So we collect, actually the right way to put it is tobacco use rather than just smoking. Okay, because people say, no, I don't smoke, but then they use tobacco in so many other forms. So anyway, let's take it as smoking. So for smoking, we look at it as pack years. We say there are different options in which we collect this. Let us say 40 pack years. What would that mean? Let me ask Satyanarayana, who always turns up on time. He keeps his video on and he gives good. So when I meet you, Satyanarayana, I give you a special prize. Okay.
Sir.
Right. So what does 40 pack years mean, Satya?
Sir, taking 20 cigarettes per day for continuously for 40 years, like that. Or
20
40,
cigarettes a day for 40 years. Does that make it 40 pack years?
no, sir, maybe 40 cigarettes per day, continuously taking for 40 years.
Okay. All right. Any other way we can look at it? Okay. Doesn't Doesn't matter. You made a very good attempt, and thank you for that.
Okay.
So it can be 1 pack of cigarettes, which is 20 cigarettes per day for 40 years. 1 pack of cigarettes per day. So that is 40 pack years. Or 2 packs of cigarettes per day for 20 years. Or 4 packs of cigarettes per day for 10 years. All of this is 40 pack years. Okay. So we say it as 40 pack years, but we also need to qualify how exactly we calculated that, just to give you an idea. Okay. Assessing outcomes. We have to be clear about it. Death is not an issue, but cause of death, we may have to do either a clinical autopsy or a verbal autopsy. Is ideal, particularly when we are doing cohort studies, to make sure the cause of death is clarified. Other outcomes of interest could be development of disease. Somebody developed depression or a complication of diabetes, stroke, or dementia, or whatever. So these are other clinical outcomes. It could be one event or multiple non-fatal events, right? So it could be one myocardial infarction or multiple myocardial infarctions. And how do we count them? So the important thing over here is we need to completely ascertain all of the relevant outcomes for our study. So therefore, we need a lot of planning initially before we do that, right? And again, the critical thing is we need to do it in both the groups, with and without exposure. Sometimes to remove any bias of the way in which people ask questions, as I said last time during the case control design, the people or the data collectors are blinded to whether they are a case or a control, or whether they had an exposure or not. Don't collect exposure data, you just collect outcomes data. All right. So these are all different tricks that people have to use to ensure unbiased and complete data collection. Okay, follow-up. We need uniform and complete follow-up in all ideal situation, right? So ask the subjects directly, look at the hospital records, look at death registries to make sure. Complete ascertainment of outcomes. We need to ensure there is no unequal follow-up between exposure group and non-exposure group, and have standardized diagnosis of the outcome. If you're doing a multi-center study, make sure that those with and without exposure, the outcomes are collected uniformly, and endpoints are determined clearly. Definitions are very simple and clear. And this is what we do when we have investigators meeting. When we design the study and we choose people, they got all their ethics approval, everything, and then we all get together. We all get together and we define things. Then people have debates. No. Why are you calling this? No, this is not stage 1. This is stage 2 according to this. Okay. We have little differences. We generally agree. The little differences, whatever we have, we put together in a consensus outcomes document. Right? Everybody agrees. All researchers agree. This is what is sensible. And many times it is an upgrade on the guidelines, because guidelines take another few more months or years sometime to come up. Okay. Very important concept. Remember last time I told you, today I will clarify what confounding is. Anybody, can you give me your definition of confounding? Not Google's definition, your definition of confounding. We talk about it all the time. Lot of our statistical work is for sorting out confounding. Anybody? I only have Satyanarayana who I can see. Just give your definition of confounding. Anyone? Can Soumya Soman try? Your definition of confounding. How about Dinesh Saravanan? If either of you are trying to talk, you all are on mute. We can't see you. We can't hear you. Okay, Satya, I'll have to come back to you. So, we also have Dr. Rama Prasad. Would you like to try your definition? Doesn't matter. I can take a break from talking. I've been actually talking from 5 p.m. onwards. I had another meeting. So let me take a break from talking. Yeah. Please try, Rama Prasad.
Yeah, a confounding factor. I think it is a third factor which is influencing the outcome, which is other than what we are trying to
Excellent.
measure.
Excellent. Absolutely right. That's it. That's the idea of keeping it simple. Do you want to give an example so that you got 9 out of 10? So now you can get 10 out of 10. No? 9 because I was so generous because you made it simple without giving
Thank
some
you.
complex definition. One example, please.
Can you give a disease to me?
Yeah, whatever comes to your mind.
Yeah, maybe yeah, what is the risk factor for obesity? Let us
Okay.
keep it simple.
Yeah.
Then it may be taking fat or lipids more.
Okay.
So if both these factors are there, one factor may act as a confounding factor for the other when in analysis.
Okay. What are the two factors you're talking about? One is obesity is
One,
the outcome.
yeah. One is sugar intake, other is fat
Sugar.
intake.
Oh,
Yeah,
sugar versus fat. Okay,
yeah,
okay. Interesting.
yeah.
Okay, interesting. Yeah.
So
Okay.
that's a
Let's
broad. Yeah.
you are very close. You are very, very close. So 9.95. Okay.
Yeah,
Why
thank
not
you.
10? Why not 10? We'll debate that a little later. Okay. All right. So, okay, let me give you an example. And there's obesity in that example. Okay. This is not AI generated slide, but it is my good old slide, which I've been using for many years. Okay. What is confounding? A situation in which the effect of two factors cannot be separated. Two factors seems to be implicated there. Okay. Another way to describe a confounding factor is an extraneous variable or an outside variable that correlates either positively or negatively with a dependent and independent variable. A little tricky to understand this. I won't spend time explaining this because I'm going to do correlation. I'm going to do independent and independent variables in one full lecture in biostatistics in a few weeks from now. Okay. So in other words, it's an external factor that influences the outcome. That's another way to look at it. Another way to look at it is the factor is associated with both exposure and outcome. This factor. That is what is messing up things now. All right. So obesity example, Dr. Rama Prasad. Okay. Low physical activity causes acute myocardial infarction. We know this. Causes, not even associated with it, causes, we know. Now, low physical activity is also associated with obesity. Now, obesity is also associated with acute myocardial infarction. Interesting. Now, if you notice, this arrow is going in one direction. This arrow is going in one direction. This arrow is going in two directions. Now, is low physical activity due to obesity or is obesity due to low physical activity? Obesity comes in the pathway for acute myocardial infarction. So if I want to know the effect of low physical activity on acute myocardial infarction, I need to consider obesity. Okay. And what we do statistically is we adjust for the effect of obesity. Okay. And what we do with confounding, it's coming in my next slide, but I'll say it now and I'll say it again. We do regression analysis. In statistics, we do regression analysis to take care of confounding. And I'll explain. For regression, we have one whole lecture. Okay. So now, how do we correct for confounding? Bias, what we have to do? Bias, we need to understand the bias and do our best to reduce it through study design, through the way in which we train people, through the way in which we collect data, etc. We reduce bias. We need to understand bias. For cross-sectional study and case control designs, both recall bias is a challenge. It is there, it is real, and it is there. What can we do? We have to be aware of it and try to reduce it as much as possible. Or choose a study design which can eliminate recall bias. And what is that? A cohort study. I just told you a few moments ago. Cohort study eliminates recall bias because you're asking them, how are you doing now? How much are you smoking today and yesterday? I'm not asking you how much you smoked 25 years ago. Okay, so coming back here, what do we do for confounding? That is bias. What do we do for confounding? We can stratify by key variables, right? So stratified analysis statistically we can do. Okay, and what we do is a simple example could be different disease severity we can take. Severe, moderate, low. Okay, and then analyze within them and see what is happening. What are the factor that is causing it to be high and a medium and low? A more or a better way to do that is matching of key variables and okay, no, sorry, let me go back. Stratification is one method which is done. Matching is another method which is done. However, the best method is using regression techniques and we statistically adjust. What is the meaning of adjusting? I heard about this word adjusting in 2001. And I was wondering, what is this adjustment? Are you manipulating data? You don't understand what that means. So till I understood regression later on, it is not manipulating or adjusting data, but it is statistically accounting, quantifying, accounting, and removing the effect of confounding factors. I'll say this again. It is understanding, measuring, quantifying, and removing the effects of the confounding factor for our outcome. All right? Okay. How do we analyze a cohort study? Okay, so in cohort studies, do we study association or do we study causation? Give me 1 second, please. Let me, there is some background noise coming. Let me try to eliminate that. Give me a second. Okay, I hope it is stopped now. Okay. 1 second, let me just sort out my slide. Okay, so association versus causation. So cross-sectional study, case control design, we assess association. That means what is the relationship between two factors and what is the strength of their relationship. Okay, but we can never tell that one caused the other. And today I'm going to give you a beautiful concept which is many decades old, and with that you will understand causation really well. Okay, so association versus causation. Association, we say X may cause Y. X is related to Y, very strongly related to Y, and we can only say X may cause Y. So in the 1960s and 70s, they were only able to say smoking is associated with cancers. They did multiple studies after that, and they fulfilled certain criteria, which I'm going to tell you in the next few minutes. And now we know smoking causes cancer. Smoking causes heart disease. So association means we are saying X may cause Y. Causation, we are saying X causes Y. Right? There is one other level we go to called mechanism of action. Okay, which says understand why and how X is causing this particular outcome. So three things we have understood today: association, causation, and mechanism. And we're going to study more about causation just now. We need to satisfy certain criteria to establish causation. We need to establish certain criteria. We need to satisfy certain criteria to establish causation, right? Oh, before that, I'm sure all of us remember the Koch postulates for an infectious agent causing an infection. Correct? Koch postulates, Robert Koch, K-O-C-H. In fact, our medical college, one of the buildings is named after that scientist. But anyway, one is we need temporal relationship. Temporal means time. One before the other. So we are clear that this was not there, this outcome was not there, only risk factor was there, outcome was not there, then the outcome came later on. That's temporal relationship. And specificity and biological plausibility, I'll explain somewhat together. There must be some meaning to it. Once again, if you go to tobacco and cancers, today we know the number of carcinogens. And if you go to the molecular level, we know what it does to the DNA. We know what it does for haphazard, multiplication of cells. So there is biological plausibility. We are not just saying out of the blue. And it must make sense overall. It must overall make sense. But let's go to this 1965 paper. Many of us were not born. Okay. So Sir Austin Bradford Hill. Okay. At the time, he was at the University of London. He was also at Oxford University. So he gave this talk, right? And this was actually in this journal called Occupational Medicine. And so he discussed association and causation. And now we have the Hill's criteria for causation. Austin Bradford Hill, that's the gentleman. So he established the connection between cigarette smoking and lung cancer. And he was at the time at the LSHTM, as they call it, London School of Hygiene and Tropical Medicine. And along with another epidemiologist, Richard Doll. Richard Doll was at Oxford University at that time. Along with them, they did, can you believe, called the British Doctor Study. They started this cohort study in 1951 on 40,000 doctors. Apparently, there are photographs, it seems, of doctors sitting in their OPD with a cigarette and writing a prescription. Those were the days. Can we imagine this now? Even in the most backward countries, I don't think we can see something like that. So in those days, so almost 75 years ago, they came up with fairly convincing evidence that tobacco smoking increases the risk of lung cancer. Sorry, this keeps jumping away. Okay, so they did the British Doctor Study, very famous study. Okay, then Austin Bradford Hill also did the first modern clinical trial of streptomycin in tuberculosis. It's accepted as the first modern randomized controlled trial. James Lind in 1700s did another trial. Anyone knows what James Lind studied? Scurvy. So James Lind figured out or kind of speculated that sailors who go into sea after many months, they are developing scurvy. Okay, but the officers, the better off people, higher ranked people were not getting this. And he said, there's something interesting. So he noticed that people, who are well off and higher ranked, those people got to eat fresh fruits. Particularly citrus fruits. So he said, let me test it out. So he did he didn't randomize them, but he divided them into two groups, and he gave one group citrus fruits, the other group no citrus fruits, and clearly those without citrus fruits got scurvy. Anyway, that is the 1700s. It's not a randomized control trial, but it's still a kind of a quasi-experimental study. But anyway, Austin Bradford Hill is the one who did this first modern trial in the 1940s and 50s on tuberculosis. Anyway, coming back. Here are Hill's criteria for causation. One, there must be a good strength of association. Stronger the association between the risk factor and the outcome, more likely it is to be causal. Remember, we are talking about causation now. Okay, stronger the association, more likely it is. Second, consistency of finding. We're getting the same findings, okay, in different populations, different designs, and different times. Same thing is happening over and over again. So there is consistency in finding. It's not going in the opposite directions. Oh, that could be causation. Okay, different people, different groups here and there, smoking, lung cancer. Oh, okay. So that is the second one, consistency of finding. Specificity of the association. When a single cause produces a specific outcome. Okay, so now we have once again tobacco. Okay, multiple types of cancers. Okay. Temporal sequence, very important. This is critical. Exposure must precede outcomes. Okay, we have a couple more. Biological gradient, or in other words, a dose response. Higher the rates of exposure, higher the chances of the outcome. Biological plausibility. I told you this earlier. It must make some sense overall. Okay, there must be a presence of a potential biological mechanism of causality. So our colleagues sitting in the lab, they sit down and find out, this is what is happening, this is what is happening. And that is what we're seeing in the clinic. That's what we're seeing in the community. Coherence. Overall, the relationship agrees with the current body of knowledge and the biology of the disease. So these are Hill's criteria for causation. So briefly going back, strength of association, consistency of finding, specificity, temporal sequence, biological gradient, biological plausibility, and coherence. Finally, an experiment. Does the removal of the exposure alter the frequency of the outcome? This is almost like a classic, or an unrefutable situation or a scenario. So I've given you 8 of Hill's criteria for causation. Now, let's look at scenarios in cohort studies. So let us, for simplicity's sake, let us take 10 patients who we are following up for 10 years. Okay. Then now we have 1, 2, 3, 4 patients who are lost to follow up. So first patient joined at year 1, little later, you see how they are joining in, right? In different ways they join in roughly. Okay. Now 4 patients are lost to follow up. Now some patients, this red dot is an outcome of interest, and let's assume this is death. Okay. So this patient died, this patient died, this patient died, and this patient died. Or let us assume it is another or a non-fatal outcome. Okay. And another scenario can happen with patient G. If it is non-fatal, this is what can happen. Do you see this gap here? This patient started in 1.5 years, came up to 3.5 years, disappeared for some time, and came again at 5 years. And for this, oh, sorry. Okay, so this patient decided. So this particular patient here had a non-fatal event of interest, but it happened before the study started. Okay, so can you see so many different scenarios? Now we have something called censoring. Observations are censored when information is incomplete. There are following types of censoring. I'll explain this again in survival analysis: right censoring, left censoring, and interval censoring. We'll skip it for now. Okay, I'll skip this also for now. We'll do this in survival analysis. Okay, this is important to know. Now, how do you calculate the duration a patient was in the study? We calculate something known as person years. Let's take the 6 patients. First patient started in year 1, went right up to 10 years and is alive and well. This patient started here at year 1, came up to end of 5 years and became a case, and we are not following up anymore. This patient lost to follow up. This patient, like patient 1, alive and well. This patient came up to 9 years, end of 8 years, starting 9 years, and then became a case. So now these people, as you see, have provided varying amount of data in your study, and we can calculate that. Okay, so this patient gave us 10 years of data, 5 to 7. Okay, it will be nice if we can mute our lines, please. Okay, so varying time periods in the study, and we can just add it all up, add up all this. So in this study, we have 45 person years of data. And in some studies, you will get 100,000 patient years. How did that happen? Okay, 1,000 or 10,000 patients followed up for 10 years, something like that. Okay. So now we go back to this 2x2 table. Exposure, disease. A number of people had the exposure and became disease. B number of people had the exposure but no disease. C number of people, no exposure, but unfortunately had the disease. No exposure, no disease, and we can add up all this. Okay, so the relative risk is what we calculate in a cohort study. Please make a note of it. Relative risk. Relative risk is the cumulative incidence in the exposed group divided by the unexposed group. Okay, so what is the incidence in the exposed group? How many people? A. How many got exposed? A by B got exposed. A is the incidence in everybody who got exposed. So A divided by A by B, further divided by C divided by C plus D. These are people who were not exposed, got the disease, divided by the total number of people who did not get exposed. So exposed divided by not exposed. Okay, so let's take some real numbers. What is our total sample size here? 160, right? If you total up this one, 160, Total of this one, 160. So this is smoking and acute MI. Just take a break from cancer now. Okay, smoking and MI. So 20 people among the 80 who smoke, 20 out of 80 who smoke got MI. 10 people who did not smoke, 10 out of 80 who did not smoke got an MI. So if we compare these two, double the number of smokers got an MI compared to non-smokers. So let us see what it is. Same formula, 20 divided by 80, 20 divided by 80, 10 divided by 80, 20 divided by 80, 10 divided by 80, 1 by 4 divided by 1 by 8 equals 2.0, double. How do we interpret this? Right? How do we interpret this? Suppose, as I told you, for an odds ratio, every ratio, if you get 1, that means there's no difference between numerator and denominator. 2 means it is twice the risk. So the way we interpret this is, those who smoke over 1 year have twice the risk of developing an MI compared to those who don't smoke. That is our interpretation of this data. Sorry, that slide skipped. Okay, let's look at relative risk versus absolute risk. This is a little confusing. It'll take you a little time, but I will mention it to you and then we can understand it a little better. Relative risk is a measure of etiological strength. That is the strength of association between the risk factor and the outcome. Even an odds ratio gives you that. But relative risk is over a period of time. An attributable risk is incidence in the exposed group minus incidence in the unexposed group. We're going to do this again in a clinical trial. So even if you don't get it now, we'll do it next week. So let's take this back again. Attributable risk is what, in other words, it's called excess risk. Exposed minus not exposed. Right? So I've jumped the calculation here for you. So look at it as 12.5. Okay. So the risk of disease in the exposed group that is attributable to the risk factor. In a clinical trial, you'll understand it a little better. So in the interest of time, I will move on. Okay. So where do we use survival analysis? So relative risk is one way. Where do we use survival analysis? When people enter the study at different time points, they're followed up for varying periods, right? And where we have large number of participants, okay, relatively rare conditions. And where do we apply survival analysis? One is in clinical trials, prospective cohort studies, as well as retrospective cohort study. These are the three places wherein we use survival analysis. Right, I'll skip this because we're going to do this in detail during survival analysis. Mean survival, survival rate, person years, actual approach. I'm sure all of you have heard about the Kaplan-Meier approach. We'll do this, when we do survival analysis, and and I'm sure you've also heard of the Cox proportional hazards model, which gives us a hazard ratio. It gives us a hazard ratio, and we're able to interpret the hazard ratio. Right? Now, I'm going to show you a table so that you're just familiar with some of the terminologies. Each of them will take one whole lecture to describe, but let me tell you. Measurements on individuals, and in groups. Outcome variable is time to an event, a continuous variable, or a dichotomous variable, or time to event in a group. So this is the Cox proportional hazards model, wherein we compute the hazard ratio and its 95% confidence interval. And I will put a double tick over here or a triple tick over here because this is what we commonly do. And I'm going to show you some examples quickly. Continuous variables, we do multiple linear regression or ANCOVA. I'm sure you've heard of ANOVA, which is analysis of variance. But when we use the covariates here, it is called ANCOVA or analysis of covariance. When it is a dichotomous outcome, such as MI, no MI, cancer, no cancer, dead or alive, we use multiple logistic regression. Okay, for groups, it is standardization. So here we go, hazard ratio or relative risk, as I told you, regression coefficient, and an odds ratio here, along with this 95% confidence interval. Let's take some examples and we'll conclude today's discussion. All right, so this is done, or this is from the American Journal of Epidemiology, from the Johns Hopkins School of Public Health in 2007, it was published. Risk factors for renal cell cancer This is a multi-ethnic cohort from California. So in California, as you know, we have lots of Latin Americans, we have people from Hawaii, and we have multiple other ethnic groups living in California. So they did the study. See how they did the study. And this should hopefully inspire us. So they collected data of 1.6 lakh people in this cohort, 1.6 lakh people between 1993 and 2002. 19 years, 1993, 17 plus 2, 19 years. Okay, they collected people, and then these people, they followed up for 8.3 years. When they followed up for 8.3 years, these people developed 347 renal cell cancers, 220 in men and 127 in women. And so let's look at this now. Multi-ethnic is a prospective study. Okay, and began, I think I told you this. They initially identified 215 men who were African American, Japanese, Latinos, Hawaiians, and white people. This is a multi-ethnic cohort, right? So they sent them actually a self-administered mailed questionnaire, and they followed them up every year for cancer incidents. And then they also looked at diet, demographic factors, anthropometric measurements, personal behavior, including tobacco, alcohol, etc., medical condition, family history, and all of that. And they tracked them through cancer registries. Right? The follow-up rate was 95%, which is fantastic. Okay, and participants with a cancer diagnosis before baseline were excluded. So about 21,000 people already had cancer. When they went and asked them, they exclude any type of cancer. Okay, so I briefly told you about Cox proportional hazards model. Here we go. That's what they did. Cox regression techniques. Okay, renal cell cancer diagnosis at a particular point in time they took. Okay, so more or less the same thing here. Let's go on now. So here is the total number of people, 75,000 men and 86,000 women almost, mean age of 59. And this are the different ethnic groups. Body mass index, 44% or about 50% were normal body mass and 50% were overweight and obese. Smoking, about 18% men and 14% women. Pack years of smoking, 20 pack years of smoking in men and 15 pack years in women. Ethanol, hypertension, diabetes, all of that. Okay, a bit of a complex table. I'm breaking it down bit by bit to show it to you. So we're looking at body mass index and different quartiles of age, different quartiles of height. So we'll only do body mass index for this one now. Okay, so number of cases among men, 77 men, less than 25 BMI, 93 overweight, 50 were obese. So the normal people's relative risk, they fixed at 1 compared to 1. Those who are overweight, the 19% excess chance of getting cancer. Those who are obese, 98%, almost twice the amount of getting cancer. This is age-adjusted model, and this is a fully adjusted model. We'll skip it for now. When we do regression, you will understand this modeling. Same thing for women they did. Okay, now for women, it was even more stronger. Okay, those women, this is fixed at 1. Those who were overweight, relative risk was 2.25, 125% increased chance of having renal cell cancer. And in those who were obese, 177% increased chance of getting. And this was statistically significant, and so also was this. We'll skip the weight and we'll go to another little maybe interesting thing, which is smoking status. Now you're familiar how this table is constructed, so I didn't animate this one. Never smokers were 48 people, fixed it as 1. 120 people almost were past smokers. Even for past smoker, there's a 50% increased chance of renal cell cancer. Current smokers is double the chance. Okay, and the same, roughly the same thing for women as well. Pack years of smoking, 20 pack years, 44, more than 20, 63, current pack years 2, and so on and so forth. Ethanol intake, interesting. Ethanol always comes up with interesting data. So no ethanol, 1, fix it at 1. So if it is less than the median, there seemed to be a 20% protection. Before all of us feel very happy and grab a drink now after this lecture, this was not statistically significant. All right. However, if it was more than the median, okay, there was a 30% reduction and it was statistically significant. So ethanol comes up with interesting outcomes, but this is not a recommendation to have ethanol. Okay, let's complete with this last example of let's take skin cancer. Okay, long-term exposure to risk factors in a cohort study. So here they looked at sun exposure and risk factors for, this is in the US Nurses Health Study number 2, which ran between 1989 and 2009. Look at the numbers here. These are nurses. Remember the British doctor study? This is a very famous Nurses Health Study. Sorry, go back. Okay, 108,000 people, 1.1 lakh people, and see the number of years of follow-up. You calculate all of that, it is 2.1 million years of follow-up. Okay. And after they did this this is the number of years of follow-up. When we add up all that, it's 2 million years of follow-up. Now you know how you get, I showed you person years. This is how we get million person years, etc. So they identified 6,955, I may get the abbreviations wrong, basal cell carcinoma, 880 squamous cell, and 779 melanomas. So that is a large number. So you have 1.1 lakh people and you follow them. I mean, with nurses, wherever in the country they go, they're always registered and then they can follow up. So these are beautiful studies that were done, and that's how we know and we have such robust data. Okay, so I'll let me show you. So this is again the Nurses Health Study, annual UV flux. Low, 34,000 people, medium 39,000 people, and high is 35,000 people who had exposure. Okay, and so they collected. So these are all the confounding factors for cancer: family history, the type of hair color, number of moles on the leg, painful blisters, sunburns, using tanning bed, body mass index, smoking, alcohol, physical activity. All these are confounding factors. In regression models, they are considered before outcomes are determined. Okay, so here we go. For bladder cell cancer, now let us see what all they have now. For bladder cell cancer, relative risk of for cumulative UV flux. So the amount of UV flux exposure is divided into 5. Okay, quintile 1 is the lowest. There were 664 people. Okay, and that is fixed. Relative risk is fixed at 1. Compared to higher, next higher 40% more, next higher 75% more, next higher 109% more. The highest level is 164% more. All of this statistically significant, and this is P for trend. P for trend means, is the increasing gradient significant? Answer is yes. Okay, this is for basal cell, squamous cell, and melanoma, and you get somewhat similar results. Okay, so you have family history, hair color, moles on leg, and all of that. As you see, complex table. We'll skip all of this. I'll skip this study that we did as well, and let me conclude in the interest of time. Okay, cohort versus case control. This is my last but one slide. Cohort study, rare exposures. Case control, rare diseases. Why do we take rare diseases? Diseases already occurred. They come and land in your lap, in your OPD, or in your inpatient. You collect your case, then you go backwards. Cohort study, rare exposures, we collect them, and we look for disease going forward. Cohort study, long and expensive. Quick and inexpensive case control. Multiple exposures, multiple outcomes. Very powerful design. Okay. And in a case control, examine multiple risk factors for a single disease. One disease has occurred, we go backwards and look at multiple exposures. Case control suited for evaluating disease with long latency period. You take 10 years, 20 years, 40 years, 50 years, I don't care. I'm waiting. When the disease occurs, you come to me. Okay, so that's how we do that. Okay, cohort on the other hand, we minimize bias, particularly in exposure determination. Okay, recall bias is unavoidable in case control designs. Okay, so friends, let me summarize the cohort design for you. Expensive and difficult. First message. Okay, at other times I tell, high quality cohort studies are not for the faint hearted. So how many people here are inspired to do a 1 lakh patient study, follow up for 20 years? You know what it takes to follow up for 20 years? Lot of determination and a team and a ability of one PI to hand over to the next PI and say, I'm retiring or I'm going to Hawaii for a holiday. You take over the study. That's how these people did it. And you will see there are 20 papers with 20 different first authors of the studies. Okay, anyway, we can estimate incidence. We can estimate strength of association of exposure to outcome very, very powerfully. We can make conclusions on temporality and possibly causation as well. We can say this causes this. How do you know for sure? Does it fulfill Hill's 8 criteria? Yes, it fulfills 7 out of 8 criteria. Yes, then it is a causative factor. All right, very valuable data. We need very high quality Indian cohort studies in India, right? So young and not so young urologists in this group, are we up for the challenge is my question for you, and I will stop with that. Happy to take questions. Any comments? Good to see you, Tanmay. You're hearing this for the third time, maybe.
Jinil, you
Yes, sir.
Jinil,
Yeah.
Jinil, you have any comments before we go to Dr. Apul for?
Let Apul sir take over.
Oh, okay.
Okay, so very well presented, Dr. Xavier, as always. Really enjoyed your presentation and your input regarding the study designs that I showed. Okay, so the examples that you gave were, epidemiological studies, and which are very difficult to do. Actually, you can't. Clinicians, I think it's difficult for clinicians to do. But as I showed in my slides, there are many studies that we keep getting, cohort studies. The one that I presented regarding radical cystectomy, patients who took neoadjuvant, those who did not, or patients who received neoadjuvant, and then we look at complications because of neoadjuvant. So these are clinical cohorts, and we do keep getting, such type of articles. So I think we are happy with those type of studies. I think if we do multi center studies, so we can have bigger data. So that's what we are attempting, and this exercise is also a step in that direction where we can involve more people, I think. So because in India the strength lies in numbers. So if we have a bigger study, and it's not difficult, we just collaborate. So, but yes, epidemiological studies looking at risk factors for disease, how disease happens. So yes, they are very difficult. Yeah.
So one of our problem is after deciding about the question, we start collecting the data. Before that, none of the hospital will be having the data. That is one issue of having a collaborative study. And if you are doing a collaborative, 10 institutes will be having data collected in 10 ways. And finally, when we want to collate all this data, a lot of factors actually will be having difference. So what we have to do is actually a person has to sit and discuss, and prospectively we have to set the data points. Then it should be a routine that data points are continued for coming days or across different postgraduates, and finally become a good steady data material in each institute. Then only probably we'll be able to have good studies across India. We are not that much focused on to data collection. That is a main factor because of which studies are not coming from
Right. Could I
So,
comment here
Janil,
on that?
sorry. Okay, go ahead.
Just briefly, because both Dr. Apul Goyal and Dr. Ginil shared similar sentiments, and I want to, what should I do? Make you uncomfortable, let us say. Okay. Okay. So, as we know, sorry if I sound cliched, the limits we have are the limits that we set for ourselves, right? So, I completely understand on one side, our strength lies in numbers, and the challenge we have is also because of those numbers. We have to deal with those patients. Okay, and therefore we have very little time. Everybody's got just 24 hours, and we have very little time for other things. So the same thing is both a challenge as well as a an opportunity as well as a challenge. The only way, and I've said this in many different institutions as well, when I've gone and given workshops and given talks, and one of the few kind of frequently given talk is building a culture of research in our institutions. For that, firstly, we need to remove that limit that we set for ourselves. Second, there is money available in this country, and lots of money is being put. Okay, I think I shared with y'all, I'm sitting on 16 different review committees of the government of India for different agencies, and crores of rupees are going. Right, so we need to tap on that. In fact, just before this meeting, I was part of another group where we were sitting and discussing as to how do we write grants and get, this is for a stroke consortium, and I was telling them the same thing. So therefore, we have to first think that is possible, number one. Number two, get the resources together, and therefore you can employ people to do the job. So there are experts who can, design the forms, who can, manage the data, and then make sure, follow up is done, etc., so that good quality data is done. I mean, I have 35 staff, so every month I'm paying, huge amount of salary for these staff, and that's how we are able to do these studies. And some of you are familiar with the work that my group is doing and has done. So it's a lot of funding that goes in. So that's what I wanted to tell you, people. In addition to the principles that I shared with you on this cohort, I purposely showed you this high quality studies which nailed the issues. In other words, they said no controversies beyond that. Okay, right? So, but we should get together. I completely agree with Dr. Ginil. The biggest problem we have is people, getting together and doing some studies and getting bogged down with the data. So that's why this course, as always, has three components: the study designs, second is data management and biostatistics, important, and the last one is research management. How we manage three M's: man, materials, and money. That is where we get lost. Even doctors even learn statistics. Okay, the struggle. The third part, so it's like a triangle, no? It equilateral triangle. All 3 points are important. Equilateral triangle, and we have to take care of that. And many groups in India are doing well now compared to even 10 or 15 years ago. Many groups have figured out and they're doing. Sorry, I after all this long lecture, I'm giving you another mini lecture. But my key point was, let us think possible and get the resources, get the experts to do it. And we must do it. I mean, if this group of ASU people don't do it, I'm not sure which other surgical group in India will do it. So sorry, I'll stop there. Dr. Arun Chawla, you wanted to say something, and I
am echo the same sentiments. The issue here is, if you see the number of participants sitting here, and you are viewing them, all looks to be in what you can say a consultant or some sort of faculty. So when you are talking about all these research design, probably we need to start it from the very beginning, that is MBBS, then the post graduation. By the time they come to the residency, they should be well aware what is happening nowadays. We have some data and we try to figure out how to use the data and make a study out of it. That becomes the problem. And we see more problem in the residents who are in surgical specialties, where the what you can say the priorities are in learning skills than in publishing. By the time they realize that this was the important what you can say, facet which you could develop in their CV when they apply for fellowship. Already the story is over. Now, even if you see, in spite of best efforts, it is this attitude, this course, or is just attempt to imbibe this sort of what you can say, the knowledge into their daily practice. And they sit over the patient, they sit over the data. But if you compare from surgical to non-surgical, there is little better understanding. You come from non-surgical to paramedical to basic, there is a much better understanding and quick adoption. Only the problem we face with the surgical specialties.
Arun, I got small difference of opinion whether I'm really appreciate that a lot of faculties are here, because I think that the change has to come from the faculty side. Why, I'll tell. There is a top-down approach or down-to-top approach. So it will be more effective if university insists that in the faculty, and faculty insist junior people and like that, because there will be some enforcement happening. So if the PGs has to change and do something, I think that is not going to happen in our country, because we were under the British rule, and we only know how to serve and don't know how to take up something and execute. That is what I feel. Sir, you are
Again, I take your point
opinion.
with a little pinch of salt. I have seen legends attending these courses with their phone on, and after full course also, they are not able to frame a single question or to plan a study on their own. They need a help at every single step. So what I'm telling is, this is need to be a continual exercise. It is not a one-time event. This has to be a continual, so that this becomes a part of their daily professional life. We realize quite late, and that's why we are here, and we want our people, what mistakes we have committed, they should not do. But still, it needs what you can say, long chalk out plan, long drawn out plan, with the different fora, inviting these people to join this community. And there's so much to learn from the masters who have already excelled in this field. And it is easy. Only thing is, needs commitment from one's end. That's all.
I think, Dr. Arun, the last part you mentioned, because it is easy, there's no commitment. That could be another thing. And one other issue, sorry, we've gone beyond the time today, we should conclude. One other issue is, during post-graduation, they say, at least MD, MS, they say there is a brief course, BCBR course. You do that, and then you get so much marks. If people mug up something, they get marks. And then the problem is, once they pass that, they think they have learned research methods. It's like maybe an MBBS student who finished internship and all that comes to you and says, "Sir, madam, I'm ready to work very hard. Teach me urology in 3 months." No, 3 months not possible. No, I'll work 24 hours. You teach me urology in 3 months. It's just not possible. It's just not possible. You have to go through that. And so these are two issues. And in a way, all of us discussing here, all of you are, it's like they say, preaching to the converted. All of you people are committed. And look at Dr. Ginil, from the first time, every session, wherever possible he comes. I've seen him in trains, in cars, inside a plane. Before the plane took off, of course. I don't know, a little later where he's going to log in with internet on the plane while it is flying, and always there and always ready. And I see him making notes as well. And you people are fantastic. And that is why he publishes papers regularly, and he gets his residence. And Dr. Arun Chawla also, and Dr. Rapul Goel. I mean, your points are so well taken. So I think the key thing is, and people, when sometimes undergraduate students ask me, I'm thinking of a research career, what do you think? I tell them this one point, and I think all of you senior people could keep this in mind. See, today, if you said for the same session, a foreign speaker is coming, and a new technology and robotic surgery is going to be told, you will have 450 people attending, or more than that, or you'll reach the limit very soon. It's important for you all to learn the skills, but that is short term, right? Short term gains. Learning the design of a cohort study is long term. Now, when you are in your late 40s, 50s, you realize, oh, after all these years, I have only 5 papers and none of them as first author, then I should do more research. And then you see your junior colleagues being invited to conference as keynote speaker. Why? Because he or she has done a research project, has a research group, and has got something to share with the world. Now, even this new technique that somebody is proposing and do we have enough research to say this is better than the best available technique, and how do we evaluate that? So the key point is short-term gains versus long-term impact, and research gives us long-term impact and true respect in society you will get when you have not only innovated new things, but also we have evaluated it and published it well. I will stop at that, and we hope next time we have some strategy and then we get more people. But I'm happy to teach anybody. If one person if is available, I will teach with the same enthusiasm. So I will stop here and over to the others to make the concluding remarks.
Dr. Chandramohan, closing remarks.
Sir.
Yeah.
Yes, sir.
Yeah.
At least for me, case control study, cohort study, and cross-sectional study, I understood the basics. And obviously, I have to listen again and again. But I feel it is useful. They're all observational studies. They can be retrospective and prospective in that, especially cohort study. So with this, at least I am listening, but I could not ask questions because I am not enough knowledge. So I was just keeping silent myself. If around more than 50 people join, I will be very happy as honorary secretary. I will try to encourage the HODs to their PGs to join. Though we also get motivated, like Xavier sir. As he said, one person also I will teach. Great, I appreciate that. Thank you for being with us, sir.
Yeah.
We will look forward for the next meeting, please.
Dr. DENIS, again, Dr. Chandramohan is somewhere outside his hospital, and he is also in a different location, but still made a point to join.
I listened everything. Last part, the multivariate analysis, the regression analysis part, I could not understand. Over a period of time when it is statistics, but today I listened calmly everything. I'm happy for that myself.
Right.
Thank you, sir.
Dr. Kenil made a point here that the notice came a little late. So maybe what we could do is, I think the next session is 8th and 9th of May, right? So we can do RCT1 and RCT2. Let us announce it now only. So Dr. Chandramohan,
Yes,
you can tell your colleagues to make the flyer and send it today itself. And a few other people also contacted me and said, what happened? Is the course there or not? I said, no, it will come. That is why I also sent you the message. So let us send tomorrow, Saturday, we'll say this is the next one. And then again on Tuesday or Wednesday, we will send that is 6th or 7th. So that 8th and that day morning as well. I'm sure you have a assistant who can help you.
Yes, no problem.
We'll
but actually, too many messages are coming. So I was, I thought the day if we send morning, afternoon, evening, they will focus on it. Then very early they may ignore. That's what I thought. But 2-3 reminders we can send. No problem, sir.
No, we'll send it early so people block off their time. After they block the time, on that day is just a reminder, and then the link comes in.
I got the point.
Okay. Thank you all.
Sir.
Good night and have a nice weekend. We'll catch up next week. Bye-bye.